Good afternoon, ladies and gentlemen. Are we ready? Yes, we are ready to host and to conduct one of the most awaited sessions of AIOC 2026. It's called as Unplanned Cut. Along with me, a dear friend, co-host, Dr. Viral Shah. He will be explaining briefly about the course or about the session. We have 8 known national speakers with us here who will be showcasing their complications, how to overcome, and as well as we have eminent judging panel here, including Dr. Mahipal Sajde sir, Dr. Amar Agarwal sir, along with co-convener Dr. Rahul Tiwari and Dr. Rajesh Joshi sir. Without any further delay, we will be starting these sessions with a brief introduction about the sessions. And mind you, there is a poll from the audience as well. So stay here, be interactive, cheer your favorite people, criticize, see what complications they have done, and at the same time, you have to tell them how to do it in a better way. Over to you, Viral, and then we start the session.
Thank you so much, Manoj. At the outset, I would like to thank the Scientific Committee Chairman Dr. Namrata Sharma, entire Scientific Committee as well as Managing Committee of AIOS for giving us this opportunity. The unplanned cut. Whenever we are operating, we plan it in details. We have got something in our back of mind, but something happens that we are not planning to do. A simple step that goes wrong, and how we manage from there. That is what this session is all about. So unplanned cut, we have got some stalwarts from all over India competing here. So they will be having a video presentation of 4 minutes with the moderators and the judges questioning them. Audience can also join. We will have fun, and let's start with our first presenter.
Dr. Kavita Porwal will be the first presenter. And over to you, Dr. Kavita.
मनोज किस से नंबर लगा रहे हैं उनको भी शीट दे दो अगर उन्होंने नंबर लगाना.
Good evening everyone and good evening judges. I am Dr. Kavita Porwal presenting a case of lost and found medial rectus during a retinal detachment surgery.
फिर कोई कलम चाहिए होगी या पेंसिल इसी से करना है. एक और अच्छा ठीक.
I have to see which one. It is not the first slide. Was this only to display this and see? No, not this. No, PPT. Yeah, do that. What's up? Time चालू जाता है. So sorry for the inconvenience. Any questions? Sir, any questions?
Wait, Dr. Kavita. We told you to show unplanned cut. You have cut the entire muscle itself.
So,
Huh?
so it was.
Wait. Your time for justification will come. You only cut the muscle and you only attach. Huh?
It was the retina surgeon who did it. I was the
How
rescuer.
can a retina surgeon cut a medial rectus muscle?
He was trying to put the buckle around, and so he was underpassing that.
Madam, do you agree?
Comprehensive surgeon.
Huh? Do you agree that she is blaming our poor retina surgeons that they have cut the muscles and they have attached it?
So the retina surgeon doesn't know the anatomy of the extraocular muscles, isn't it?
No, I would like to explain on this. The retina fellow, actually it was a case of lipodermoid, and the muscle was attached to the conjunctiva. It had lot of adhesions. So while dissecting the lipodermoid by mistake,
Everything happens by mistake only in
Yes,
ophthalmology.
yes.
Huh? Nothing happens intentionally.
but timely we have, with the team approach, we have recovered the muscle, and the patient was ortho on post-op day 1.
So that we will decide later on.
Yeah.
Patient was ortho or exo. That we will decide.
Wonderful
Any
surgery.
comments from the judges? Maipal sir?
Dr. Rajesh Joshi sir is ready with.
I
Yes,
think she has done a good job of solving the poor retinal surgeon who made a mistake, his surgery, and she has saved that patient's eye. Thank you very much, Kavita.
Dr. Rajesh?
Dr. Kavita, very well managed, I would say.
Thank you, sir.
In fact, retinal detachment surgery itself is a complex surgery, and if you get a complications like these complications and you manage it properly, it's really great, amazing.
Thank you, sir.
Amazing.
As we all know, medial rectus is the most commonly lost muscle and most difficult to retrieve. But we were lucky that we found the fibers attached to the conjunctiva, and we were able to retrieve the muscle and attach it at proper place. Thank you, sir.
Yeah, very well managed.
Wait, 1 second. Any comments from the audience?
Hope you have not charged for the
Wait,
squint
wait.
surgery also.
We have one comment from the audience.
Hope you have not charged the patient for the squint surgery
No,
also.
no, it was ortho.
I guess now we can call it not a retinal detachment, medial rectus detachment surgery. Something like that.
That was a good one. So, what should we do? We need an audience vote for this. Dr. Kavita, can you raise your hands? Can we have a show of hands? She did a good job or no?
मार दिया जाए छोड़ दिया जाए.
Huh?
कोई नहीं
Thank you,
छोड़
Dr.
दिया
Kavita. You did a wonderful job. Keep it up and keep showcasing your talent like this in years to come. Thank you so much.
Thank you, sir. Thank you.
Next, we call upon Dr. Manish Wankhede. He is one of a silent entertainer. Keeps entertaining with his complications because he's a very complicated surgeon. Correct, Manish?
Very complicated personality,
Hello, dear friends.
but a simple surgeon.
Welcome to Sri
Dr.
Gajanan Netru
No, 1 second. We need the video on.
Today,
Now start.
Okay.
Over to you, Manish.
Okay. Good evening, everyone.
we will be discussing a case of 60-year-old female who is one-eyed, high myopic, and have a hypermature cataract. Most of her lower one-third of the cornea is covered by a dense vascularized corneal opacity. She is desperate to see the world, and it was difficult to take the decision whether to operate this case in a private institute or not, but I took the chance and started the case. To plan with the initial small microrhexis was intended so that I can plan and extend the rhexis on latter part. So initially starting with a needle and then completing a miniature rhexis with the help of forceps, washing all the loose cortex with the irrigation aspiration cannula will remove the tension inside the capsular bag, and this will help us to enlarge our rhexis with the help of forceps. So and again injecting the viscoelastics inside the anterior chamber and filling the bag with the viscoelastic so that there is a very small nucleus floating inside the bag can be handled. Taking the incision over the capsular rim with the help of microrhexis scissor and slowly enlarging the capsule and the rhexis with the help of microrhexis forceps. Actually, as initial part, I lose the control over the capsule due to corneal opacity as it was not visible, and it was again a better because the larger part of the rexis open area was in the visible part of the cornea. And now we will start with the phacoemulsification procedure. There was a major challenge in the phacoemulsification. It is a high myopic eye, a small nucleus, and it is small but hard, and there is a loose bag, and most of the area is not visible due to overlying corneal opacity. So to start with, I adopted a new technique in which I shifted in between chop and quadrant removal. So you can see I moved the nucleus in a visible part of the cornea, chopped it, and once the chopping is completed, the separated piece is then removed with the help of quadrant removal again. Again shifting to the chop mode, again moving the nucleus in a visible part of the cornea, moving it away from the opacity so I can visualize it, and then visible nucleus is chopped, part is separated, and again shifting to the quadrant mode, the nucleus, the separated part is removed, again moving the nucleus, and this procedure goes on until the whole of the nucleus is removed. Once the nucleus is completely removed, bag and anterior chamber is filled with the viscoelastic, and exactly what we have followed while removing the nucleus, opposite thing is done while removing the cortex. First, the cortex below the opacity is removed, and then the cortex below the visible area of the cornea is removed, so that we will be sure that there is always a cortical support while removing the blindly the cortex below the opacity. So there is the opposite approach while removing the nucleus and while removing the loose cortex. The single piece hydrophobic monofocal IOL was implanted in the bag, and once the IOL is implanted in the bag, make sure that the whole of the both of the haptics are below the capsule. So this is 3.5 diopter intraocular lens, which was ordered by an Indian company. And once the IOL is implanted, the complete removal of viscoelastic is very much important, because in such large high myopic eyes, there is always a chances of lead behind the viscoelastics, which can later date create an inflammatory reaction. To make the patient more and more gain from this corner cataract surgery, I injected a pilocarpine and triamcinolone acetate inside the anterior chamber, and decided to go ahead with a optical iridotomy. So, with the help of micro scissor, multiple small incisions were taken on pupillary sphincters so that it will remain dilated in the area where the cornea is clear, so patient can gain maximum vision, and it will not be get hampered when the pupil will get smaller. So this optical iridotomy will help the patient to see more and more in the upper part of the cornea. Thank you very much. After day 15, patient has received the vision of 618, which is more than her expectation and our expectation, and will definitely change the way she wants to see the world.
Well, well, well. We again told you to come for an unplanned cut session, not for a iris cut session.
Yes, sir.
Surgery done wonderfully well, but let me hear from the boss himself, who would have advocated straight away. Repeat with me. P, P, P. Huh? Correct, sir?
Correct.
You would have advocated a PPP for this patient.
I think it's
to
a very
give
good surgery done by Manish, but just one small thing. See, understand the previous concept is to make it large. So you will get that light inside, I agree with you. But the astigmatism and the aberropia of this patient, if you measure, instead, the scarring is there. You'd made a 1 millimeter pupil, you'd have gone to 6966 with a N6 vision. But it's a great surgery done. But what he's telling is right, Manoj. Just keep it and find your next case which you're doing. Make it a pinhole. Don't think you have a scar, that optical iridotomy game. That's an old concept. Instead, if you make it a pinhole pupillasty, game is on.
Okay.
You understand me? Just make the pupil smaller, 1 millimeter, off center from the, so that you're missing the scar, that's all. But otherwise, it's super surgery.
One is you are missing the scar. The second most important thing, as highlighted by sir, is higher order aberrations.
Correct.
See, we are measuring vision 612, 615, all those kind of things, but we are not measuring the astigmatism and the higher order aberration. The main advantage of PPP, what we have seen, the second day itself, patient is walking without glasses. So you are cutting and negating totally higher order aberrations, giving them a nil astigmatic vision. very, very important in this thing. Yes, sir. The
Locarpine is not going to help because you are already done multiple sphincterotomies.
multisphincterotomies.
And the concept of what was said earlier, the concept of making a pupil large is an obsolete because you are putting too much light into the patient's eye. And a large pupil, as you all know, is not going to give you a point focus. And in this particular case, it's an eccentric corneal opacity. It's not in the center, and it's a leukomatous corneal opacity. It's not so the kind of problem that the patient is going to have is not going to, whether you do a pinhole pupilloplasty or if you don't do a pinhole pupilloplasty, if you do a contact lens rehabilitation with an RGP later, the patient is again going to get 6/6 vision. That is the thing. And normally in such cases, the only thing I don't want to comment was because the power you were showing as 3.5, but supposing it was a 6/7 power, I would go in for a toric implantation, because this particular patient his astigmatism is stable. It's not going to change. So you can actually plan for a toric lens if that is available. With the 3.5, you'll have to have a customized toric lens to be made. So that is it. Whether you do a pinhole pupilloplasty or not, that's something different. But this extent of corneal opacity, give the patient a chance without doing any sphincterotomy and distorting the pupil. That's my this thing.
See, Manish, this case may advantage, Manish. The advantage in this case is, as Maipal said very clearly, it's off-centered. So there's a big advantage. So if you would have made it a center now, it's actually an off-centered scar, which is very easy for you to do the pinhole.
Yes, sir.
Great job.
Comments from the audience. Don't leave the presenters like this. Huh? They are showing their complications, and we need to make sure that they remain in the complicated state, not in the uncomplicated state. Okay, Manish, thank you so very much once again for your wonderful presentation.
Thank you, sir.
Thank you so much. Next presenter is there, or they run away?
They are all roaring to go.
Roaring to go. Okay.
So next one is Dr. John Davis, Akkara.
For the benefit of the audience, this course or this session was introduced 6 weeks back from AIOS office. And within a couple of days, we had such an overwhelming response that we needed to stop the entries. We have almost close to 100 entries. Very difficult to choose only the 6 or 8 presenters.
So there has been a pre-selection.
Yes, sir.
Yes, sir. It was a filtered selection.
Filtered selections.
Because
And
the overwhelming response. Over to you, Dr. John.
they shifted the session.
And pupil problem. This 74-year-old lady presented with advanced glaucoma, status post, strab in both eyes, and immature cataract left more than right. Note the awkward position of the right hand side port at 10 o'clock position because the bleb extends from 10 o'clock to 2 o'clock. The left hand side port is at 5 o'clock position and is used to inject trypan blue dye. Look carefully at 11 o'clock position. See how the trypan blue dye enters into the bleb and stains it. That shows a functioning filtering trabeculectomy bleb. Avoiding damage to the conjunctiva, a temporal clear corneal incision is made. Because of the small pupil, a BHEX 2.0 ring is used. The ring is inserted into the anterior chamber using the BHEX forceps. Then the alternate flanges are tucked under the iris, and this allows the pupil to dilate to 7 millimeters. The third and last flange is often the most difficult one to engage. You might have to use a Sinskey hook to hold it and use a BHEX forceps to bend it and place it under the iris. Then you can continue with capsulorhexis. Here the capsulorhexis is initiated with the right hand, and then halfway through it is found to be difficult to continue using the awkwardly placed 11 o'clock side port. So I switch hands and continue the remaining part of the capsulorhexis using my left hand. Beam ambidextrous is a very useful skill for an ophthalmologist. Hydrocannula is used to wash out the capsular remnant and some viscoelastic. Then hydrodissection is done. The dialer is used to dial the nucleus to make sure that the nucleus is freely rotating. Phacoemulsification is done by stop and chalk technique, where first a trench is made and the nucleus is divided into 2 halves, then rotated, and then the halves are chopped into quadrants. The quadrants are also further sub-chopped into smaller pieces. Care is taken to do the phaco under low parameters to avoid damage to the bleb. Viscoelastic is replenished as necessary, and care is taken to avoid damage to the endothelium as well as the capsular bag. After the nuclear management, cortex is removed by using bimanual irrigation aspiration. First, the aspiration is in the right hand and irrigation in the left hand, and once half of the cortex is removed, the hands are switched and the irrigation is in the right hand and the aspiration in the left hand. The cortex is completely removed and then the anterior chamber is filled with viscoelastic. A foldable single piece monofocal intraocular lens is implanted into the bag and then dialed into position using the dialer. After the anterior chamber is replenished with viscoelastic, the BHEX pupil expander is disengaged by holding the center of a flange and pulling it into the anterior chamber. After it is disengaged, it is removed by pulling it out with a corner. Viscoelastic is washed out by using bimanual irrigation aspiration. The incisions are hydrated and the pressure is titrated. The preoperative visual acuity was 3/60. Postoperative improved to 618 on post-op day 1, 69 on post-op day 7 and 66 parts on post-op 1 month. Thank you.
Thank you, John. Wonderful presentation, but I'm slightly confused. What are you going to show us?
So
The pupil is on the BX,
So,
still maintaining the BX, that's what.
sorry, so that particular image is not the post-op image of this patient. So sorry about that. The pupil was round at the
I think Suven should see this.
right. The pupil was round at the end of surgery. This was another pupil actually.
So
when we
judges, I
edit-
don't need to say more. You know.
Sorry about that part.
No, you cannot be sorry. You have to be hanged.
Yes, sir. That third image. So when I edited the video, I had a collection of BHEX pupils. So accidentally.
So it was an unplanned cut.
That was
in the
another unplanned cut.
First of all, I'm going to take a copyright of that image, send it to Suven. Okay, Suven is going to hang or
No, you will be happy. Permanent BX implant introduced.
So when you have a rigid pupil, if you don't, stretch it a little bit, you will get some hexagonal pupils.
Okay,
That was unplanned.
we have very prolific phaco-emulsification surgeons here.
No, I was going to ask him what was unplanned, so he said the picture that I put was unplanned.
The trypan blue going into the bleb was unplanned. The
What?
side port
Sorry, what was unplanned?
The trypan blue going into the bleb was unplanned.
No, that there is nothing unplanned. If the bleb is functional, you put this thing. Even the bleb at times in plates, even with the BSS.
Yes.
So I don't know what was.
So the position of the side port, I had to put it at an awkward
So
angle.
that's something which shouldn't have been done by a good surgeon, right? So basically, when you are chopping, etc., you don't want to be like this.
Just the right hand, sir, not the chopping side
No,
port. The other
जो
side
आपका side port
Plexus.
है या incision है, it should not be 90 degrees or away from where the main port. That's the basic concept of this thing because
So
it makes it more
left hand was
difficult.
fine. Left hand was
It was a planned side port, but it was a poor planned side port. Not unplanned.
I think capsulorhexis, which he should have done with the help of capsulorhexis forceps, would have been unplanned.
Okay.
I had to use that
Yeah,
side
you
port
used
because
that
I
another side port.
yes, and I had to
See, the
use the other
problem
hand.
is that if you are having a problem with the side port, you can make another side port. Okay, so there is nothing great in creating another, like when you putting, this is a BX you're putting, but when we used to put iris retractors or whatever it is, you made to
Many
make
side
4 and then you had a side port and then you had a main incision. So if you are having difficulty with the side port being inappropriately placed, you can go ahead and do that for the next time.
Okay, any comments from the audience? Anyone? Okay. Thank you so much, John.
Thank you, John.
Thank you, sir.
Coming next is Dr. Rohit Bang from Chhatrapati Sambhaji Nagar, and he will be showing us unexpected capsular bag dialysis.
Over to you, Rohit.
Thank you. At the outset, I'm really thankful to the organizers, fantastic jury, and the host, Manoj sir and Viral Bhai. So this was a case of a routine phacoemulsification, and as you can see, it's a round, regular, well-dilated pupil and a beautiful rexis. As you can see, it's a nuclear sclerosis grade 3 and one of our phaco trainees who's doing this surgery. And a beautiful rexis. So far so good, all things going as per the plan. And what is unplanned? Lot of things to come in further. You can see that trenching is going, but along the trenching there is a unnecessary stress on the nucleus. And as we try to do during our fellowship days or something, with a superficial trench, she's trying to crack. If that was not enough, now she's trying to rotate the nucleus and trying to trench it from the other side. So this should have been planned better way, and it's going in an unplanned manner. So a lot of rotation and a combination of excessive stress and unnecessary rotation. What you'll end up, or what you are most feared, is a zonular dialysis. That is what we are fearing. So still trying to crack, and there is a zonular dialysis which is close to 3 or 4 or 5 clock hours. So the primary consultant from the institute comes up into the picture. There could be two school of thoughts. Either convert this into a SICS and just finish off. It's a dreaded situation that whole of the nucleus is in the back and you have a zonular dialysis. But then additional use of iris hooks, efficient placement and efficient phacoemulsification, what I will call. Completing phacoemulsification, IA, and then removing these iris hooks and having a reassessment what need to be done next. So what we note here is not only a 5 to 6 clock hours of zonular dialysis, but a small PCR also. So we decide a good faith prevails and close down the case for today and take up on another day. Here we are planning with a secondary IL in a form of a iris claw lens. So again, 2 side ports, a thorough vitrectomy done, any capsular tags which are remaining behind has to be removed, and then come up with a posterior iris claw lens. So this is iris claw lens holding forceps. As you can see, it really gives a very good stability. A temporal and a nasal enclavation, and just when we feel that the enclavation is done or everything goes according to the plan, lots of unplanned things further comes up. We are in a state of delusion, round pupil, regular good looking pupil, but then next day morning our delusion is short lived and we have a entire iris claw lens which is hanging in a mid-vitreous cavity. So what next? Again, take up the patient in a OR and make sure that you don't disturb the enclavation which is present somehow on the other side. Try to bring this iris claw onto the pupillary plane without damaging the endothelium anteriorly, the iris in the mid cavity, and make sure this iris somehow which was fortunately hanging there doesn't drop down. So it's a tedious job with a repositor in one hand, with a dialer in the another hand, and lots of viscoelastic in my hands. I'm just trying to make sure that the iris claw lens lies flat so that its orientation is 3 o'clock and 9 o'clock what we want it to be. So giving an optimum time, and when I'm sure that I'm not going to lose this further, pilocarpinize the pupil and then make sure your orientation is good, and then go ahead and hold this again this lens with your forceps and go ahead and do the enclavation. The carry home message would be, once you see the 2 dimples and this, either you can call a smiling pupil or little ovalization of the pupil, I'm very sure this patient had a good outcome. He had almost 612 vision or something unaided. Thank you.
Rohit, I think I know you from fellowship days, correct?
Right, sir.
Yeah, right. Do you admit these patients or they are daycare procedures?
These are patients which are coming for phaco camp patients or something, and these patients remain admitted.
And they never get discharged?
No, they get discharged
because you have to operate subsequent days.
No, he charges for every OT visit 3 times.
That is but the patient doesn't get discharged because every second day he has to operate, right?
Fortunately, we don't charge for these patients. Whenever some complications are there,
we don't know. Whatever you are telling, we are agreeing. That we don't know whether you charge. Trainees you must be charging, correct? Or that is also
trainees refuse to pay.
No, trainees का number बढ़ गया ना 3 surgery.
comprehensive fellowship being offered.
So every department is covered, I think. Only
At
that-
times, if need arises, yes, everything comes into the picture.
Yes, very well done. Unplanned totally. Joshi sir, क्या चल रहा है?
Yes,
क्या कर रहा है रोहित? You are
No,
next.
no, he managed it very well, I would say. But he could have planned for endocapsular ring at the beginning only. I think there was 2 to 3 clock hours of zonal dehiscence.
No, there was a, like at least 4 clock hours of zonal dehiscence. I would have still planned, but when I finished my FECO, I noted that there is a small PCR also. So at that point of time, the putting up a CTR was not a good idea, I thought.
No, CTR could have been put earlier. No, you don't put it when you see a PCR. The point is when you had a zonular dialysis, you're just putting the hooks. Better to put capsular hooks rather than iris hooks, that's point one. But a CTR at that time could, जो trampolining आपकी हो जाती है, which causes a PCR because the whole thing is lax. That could have been avoided because in any case, if there is a dialysis, you would prefer to put a endocapsular ring. So
Maybe with entire nucleus in a position or something, I thought putting a CTR might not be a
no, so
easy job.
the golden rule for a CTR is don't put it too early and don't put it too late. So that's the thing.
Also
but
one-
yeah, sorry, go ahead.
Also, one more thing, Rohit, when you have this, it's like a dialysis, large one which has become, bring the whole nucleus up and
Yeah,
do a scaffold.
Okay.
See, you're lucky you didn't drop down the nucleus. If you had put an IOL in behind the nucleus, above the iris, you'd have had a support. Then that PCR also would not have happened.
I'd be like, with a 4 or 5 clock hours of zonal dialysis, even putting a lens or something in the bag.
No, not in the bag. You're
On
putting
the
it.
sulcus, yes.
No. Please understand. You're putting it above the iris.
Above the iris.
You're bringing the nucleus on top manually. Nucleus has come in front. Then you put the IOL between the iris and the nucleus. So you've created a capsule support.
the iris surface,
Then you can
ACI.
put the lens wherever you want.
And also in such cases where you had so much of inflammation going on, we would have avoided a iris claw lens. Even at a secondary procedure, a glued IOL type of IOL would have been a much better option than, because you're not touching the iris at all.
Right.
You're respecting iris.
See, the only other thing is whatever you told at the end, the smiling pupil or whatever it is, that could have been observed even in the first shot when you
First
did
shot
the
itself.
first enclavation. As to obviously there was a deficiency in the enclavation that you did.
No, definitely the first enclavation, whatever on the nasal side, it got disenclaved, or to begin with, might be that it had not been sufficiently enclaved.
Yes,
so वही
audience.
Okay.
Your voice. Anything someone would have done differently?
Also, Rohit, have fluid in the eye. So you're doing the whole surgery without fluid. If you have a
Yeah.
trocar AC maintainer or something, no, you need fluid in the eye because you'll see you're struggling. If you have fluid in the eye, the chamber is well formed.
AC maintain or something.
Yeah,
should be put
anything.
up.
Your choice is yours.
When there was, can I?
Yeah, go ahead.
Yeah. If when you noted that there is a PCR also and CTR cannot be placed, I would have gone with the AC maintainer or a trocar cannula and did the glue dial there and there itself.
No, I think this patient will become next year as well because Rohit has admitted this patient.
Not yet discharged.
Not yet discharged.
Patient will come for DSEC.
we'll showcase her next year.
Okay.
Rohit, thank you so very much.
Thank you.
Thank you.
Thanks for your
Great
spirit, huh?
great surgeries as always, Rohit.
Thanks for your spirit.
Next we have got Dr. Harshul Tak, the home boy with home advantage. He is going to say about iatrogenic anterior and posterior capsule rupture in case of planned toric IL.
Yeah. Thank you so much, Dr. Viral and Dr. Rajesh.
By the
Dr.
time
Manoj.
Harshul is setting up, Harshul, you have to take care of us during the banquet today, okay?
Yeah, of course.
Because the award is from the audience, not from the judges.
Of
तो
course.
हम फाड़ दें इसको.
नहीं फाड़ना नहीं है सर. हर्षल
आप सिर्फ QR कोड जनरेट कीजिए सर.
QR कोड.
आपका तो ऑलरेडी
जब हमारे नंबर ही नहीं है इसका तो.
आपका तो ऑलरेडी स्विस अकाउंट चल रहा है उधर हर्षुल के पास.
हर्षुल के बाद.
मेरा वो ग्रामीण अकाउंट है.
वही ग्रामीण
मैच नहीं होता स्विस.
You are telling सर का लेवल ग्रामीण बैंक में?
मेरा ग्रामीण.
उसका लेवल.
I said my account is
सर देखिए
ग्रामीण
क्या
बैंक.
स्टेज पे बोल रहा है आपके लिए.
सर मैंने बोला ना.
आपको अपने कान टेस्ट कराने हैं. उसने ठीक बोला.
एक बोला कर.
चलिए.
भाई एक ही वीडियो दिखाना है.
एक दिखा.
एक ही दिखाना है.
Thank you so much and
Okay, Harshal.
congratulations for initiating this new session in AIOC. I must congratulate. So this was the case which was planned for toric IOL implantation. Patient had a 1.5 diopter of astigmatism, and other eye had already been implanted with toric IOL. Wait, let me just. So this is the marking which I'm just doing, where the lens was supposed to be planted. There are side port incisions, so everything is just routine as such. Just put viscoelastic, make main port incision, and rhexis was made, and patient had some element of posterior subcapsular and polar, but this is a hydrodissection which is being done. So I was taking care because there was a slight subcapsular changes were there, so I was taking care that and everything was going as planned, and the entire nucleus was out, and as a routine just before doing bimanual IA I just put viscoelastic, so I was just injecting viscoelastic in anterior chamber, and suddenly you saw what happened. The cannula of viscoelastic jumped off from the syringe, see in slow motion, jumped off, and I had a blackout. So at that time, I was not sure what all has happened. So just as I inserted irrigation cannula, I realized that PCR is of course there, and along with that vitreous prolapse is also happening. So I just go ahead and maintain chamber, put OVD, and then plan to do vitrectomy there before going for irrigation aspiration. So we need to cut entire vitreous in cut IA mode, do good vitrectomy to clear anterior chamber from all the vitreous, and again do some staining there to check for. So it's important that at this stage we don't try to do irrigation aspiration without cutting vitreous, and once you have that, always maintain closed chamber. So still I was not sure as if what is the extent of TIA because of the cortical matter which is there. So this is just IA cut mode now. I am taking off this cortical matter. So now picture was getting clear that there is not only a big PCR which is there, but also anterior capsule has also been ruptured. So again I am always maintaining closed chamber before exchanging my hands. And again, so you need to be in IA cut mode here. So clean up the entire capsular bag, and at the same time I was thinking as if how to fix whether to put toric IOL or not, because of the big posterior capsule defect which is there, and moreover the axis was also in the same side, and anterior capsule there was no option of reverse optic capture also because anterior capsule was ruptured. So I thought that this is not the right thing to put IOL, toric IOL in this case because of the situation, and there was no backup 3-piece lens available because it was all unexpected in this case. So I decided to defer the IOL for the next sitting, and after 2 days I went ahead and explained to the patient that they're going to put IOL after 2 days, and see this is the after 2 days I go ahead and put some viscoat there and put a 3-piece IOL in sulcus and try to do whatever capture is possible. So put this IOL, and later on after 1.5–2 months I did surface ablation to correct the corneal astigmatism, and patient had a good visual acuity in the hand. So my take home from my side is just that it's not that you need to put the IOL. You can defer the IOL placement for next sitting depending on the case.
Take
Yeah,
home will
thank you.
decide.
Yeah, yeah.
You
I know.
take home will decide. Patient was discharged or admitted?
No, no, we.
Daycare.
Yeah, just after half an hour they get
And
discharged.
charge for how many procedures?
Only one procedure.
Only one procedure.
Even PRK is also included in that.
Even PRK is also.
And
included.
also the money of toric IOL was returned.
So basically, you wanted.
Wow.
Basically, you wanted to use
See,
all the
if you are
instruments.
honest,
No,
your
no, no.
patients are going to be with
The
you.
only unplanned cut in here is the fees, I think.
And you wanted to use all the equipments available in Rawat Eye Care, correct?
Yeah, of course.
Oh. Judges, any comments?
I would personally say well done surgery and good take home messages, because I would have also done. The only thing is maybe it was a 1.5 cylinder. It might have been, you could even get away with the glasses, but surface ablation करा है, that's pretty good. But पता नहीं 2 दिन तो नहीं लगते लेंस आने में. मैं तो पेशेंट.
नहीं सर, पेमेंट ग्रामीण बैंक से हो रहा है. Transaction takes.
So normally, yes, if you have normally we do have the lenses. The only other thing that we'll wish to say is that there is a change in the A constant that the people should be made aware that instead of the bag, if you are putting it in the sulcus, that's about it.
Yes.
And
Yes.
ठीक है, मतलब if you don't have the lens, you can defer it. That's pretty good. I would have possibly done the same thing. The only other difference is maybe because you may not be a posterior segment surgeon, but it's best to do a vitrectomy from the back rather than the front, because there's no way that you wouldn't have got a huge rent because the needle. And one other thing that is there is that most of us use HPMC. And when you are using HPMC does not have a pseudoplasticity like a Helon has. So what we try to do is that because you get a good cannula of a Helon, you try to put it onto HPMC, and that is one of the reasons, because it does not have pseudoplasticity. You push and it kind of goes off. So that is the only thing, that you need a larger bore cannula for HPMC as compared to Helon.
And somehow in this type of cases, I don't think optic capture works very well.
No, it won't.
Yeah, it
There
doesn't.
is no
huge
anterior
Huge anterior tear, so
anterior posterior
Yeah.
दोनों गए.
the other ideal solution should have been a,
So had there been anti-capsule was not ruptured, I would have done reverse optic capture. Put the IOL in and do reverse optic capture.
But one sensible thing, one sensible take-home message from this is, if you are not comfortable putting the IOL on the same sitting, you can defer it for another day. So it gives you time also for thinking. Audience, your comment. We are having a very silent audience. This is not correct.
Silent hall, silent audience.
Don't think Harshul is sponsoring your dinner, okay? Any comments, madam?
Why no backup was there? Backup should be there.
No, ma'am.
In each
Backup,
case.
you can't have backup for each and every lens. We
Then
do
you
have-
cannot operate. Madam, master is there. Master is telling you backup has to be there for everyone. There is no, we cannot challenge this.
No, you can't have backup for all the powers. You know, all the
whatever it is,
powers you
backup
can't
has to
have
be
backup.
there.
Of course, if you have backup, as
No,
my
point
master
well-
said, we could have put the IOL in the same sitting.
No, the point well taken. Backup has to be there. Okay, Harshul, thank you so
So
very
anyway,
much.
one question: why did you come late?
सर वो ग्रामीण बैंक
That was unplanned.
सब ग्रामीण बैंक से चल रहा है सर यहाँ ट्रांजैक्शन आर स्लो.
Very well managed by Mr. Tough.
Thank you. Thank you.
A tough case managed well. Yeah.
Harshal, very good.
Rahul, you want to tell him something?
No, fine.
Okay.
I just wanted to know कि you were while the case was over. In fact,
Madam, you
most
come.
of the time we try to put irrigation or visco from the side port and then remove the probe. That was one thing which I observed. Probably you did not put any visco through the side port when you removed the probe. That was the one thing. And second thing, why you injected visco or saline through the side port? Through the main incision, sorry, when you got a rent.
Injection of visco through the main incision should have been avoided, as should have
No,
gone.
what is
While
what is wrong in-
withdrawing your probe, you should have first injected visco from the side port.
that
and
I
not-
always do. I always do visco exchange. I always maintain, even at every step, even in bimanual also, if I'm changing my hands, I should, maybe some step must have missed. Otherwise, it's a routine practice to maintain closed chamber. That is the key in preventing further vitreous loss and
Yeah,
everything.
fine. Might be a step escape. This second thing was you injected viscoelastic or saline through the main incision
Viscoelastic.
before removing the cortex with the from the side.
Oh, there was viscoelastic.
That was viscoelastic, and cannula hit the.
AC maintainer was also there.
Yeah, okay. You're saying why it happened?
Yeah.
So that's just a routine practice that before starting irrigation aspiration, I just put some visco to maintain chamber. That's it.
Okay, Harshal, we'll take the discussion off the dais.
Yeah, yeah.
Maybe
Dr.
later on we
Shubhangi
can discuss.
Bhave madam is waiting.
Is this the last presentation?
No, two more are there, sir.
कहाँ है?
है presenters are there.
तुम आगे पीछे क्यों कर रहे हो? Confuse करने के लिए?
नहीं कंफ्यूज करने के लिए नहीं, मैडम इज थोड़ा सा तो रहना चाहिए ना सर, अनप्लान्ड. Everything should be unplanned. There is nothing planned in this session.
Okay.
Dr. Shubhangi Bhave madam doesn't require any introduction. She is teacher of teachers, well-known strabismologist from India. I will say one of the iconic strabismologists of India. Over to you, madam, for your presentation.
Thank you, Manoj, for that wonderful introduction, and I thank Viral and the organizers for asking me to be a part of this new session. This
इधर चला मैं उधर चला जाने कहाँ मैं किधर चला इधर चला मैं उधर चला जाने
and he
कहाँ
had a very large exotropy of more than 100 prism diopters and a grade 4 adduction deficit, which told us that the medial rectus was somewhat hypoplastic, not acting well, but rest of the movements were normal.
इधर चला मैं उधर
You
चला
can see the eye is not going in.
मैं किधर चला इधर चला मैं उधर चला
We were confident of a good result because it was a very large angle squint.
ये तूने क्या किया
So we had planned. So we planned a supramaximal recession in both the eyes. We did about 18 millimeter of recession of lateral rectus because it was a very large angle, and put it on a hemi hangback because we can't get this large recession without doing a hemi hangback. And medial rectus was found to be hypoplastic on the right side, and we did a modified Nishida's procedure to the right because we've already recessed the lateral rectus muscle. And after doing this, on the first post-op day, I was very hopeful, but the squint was not corrected. The adduction in right eye was somewhat better, but not good. So what do we do now? And since we have to preserve the anter-segment circulation, I wanted to avoid doing a naps, but since this is an unplanned thing, so we did a naps, did a vessel sparing naps on the other eye, thinking that this will help. And see the muscle, how hypoplastic it is. So we are attaching the superior rectus, and a foster augmentation suture is given with 5-0 at the bond about 8 millimeters behind, and the inferior rectus is also tied to the medial rectus. And again a foster is applied. So we thought that this procedure would help us to reduce his exotropia, but the eyes refuse to align. They remain exotropic in spite of doing such large recessions in the both eyes and muscle transposition on both the sides. So what could have been done to improve the exotropia was the question to the audience and to the panel.
Madam, thank you very much for the wonderful presentation. I will say all of us have been exotropic now, right now, after seeing it, rather than giving you solution. The eyes are squinted for all of us. What is your thought? What you would have done more or less?
Yes, that's what I thought, because since the vertical movements were normal, the other thing which we can do is periosteal fixation of the medial rectus to the medial orbital wall, but then that would restrict the vertical movements. So, or LR split MR, LR transposition to MR, but the LR was quite tight, so that option also was not suitable.
I think we have another pediatric ophthalmologist in the audience. Any comments for the ma'am? No?
We've been in medical school and listened to ma'am since those days. So as Dr. Manoj said, we are all exotropic. That's it.
Madam, what were the patient's expectations before surgery?
Thank you. Of course, they wanted a straight eyes, and I was happy that I got a patient with such large exotropia. So I had promised him that I'll give you at least a 60 to 70% correction. But even after 2 surgeries, I explained to him, they were, thank God the patient was not on me.
Any comments from the panel?
Yeah, refer to Dr. Pradeep Sharma.
That I'll do gladly.
Gladly. बाकी हमें नहीं समझ आता.
I think we
sir,
can.
My part, sir, will that result?
Okay, I think she deserves a huge round of applause. Coming in this competitive session at such a stature. Madam, thank you so very much.
Very good afternoon, everyone. I'm Dr. Avilasha, and it's indeed my privilege to present my surgical video in front of so many experienced ophthalmologists here. Especially, this is a video from my fellowship when I was doing in PGI. So, video. Child with both eye primary congenital glaucoma.
AVT, we can have the video here.
Was planned for right eye combined trabeculotomy and trabeculectomy
Volume.
for uncontrolled IOP under general anesthesia. Corneal traction suture was passed for improving the
Volume,
exposure of
increase
the
your volume, please.
Conjunctiva was cut. With Vanas's 8-year-old child with both eye primary congenital glaucoma with operated goniotomy was planned for right eye combined trabeculotomy and trabeculectomy for uncontrolled IOP under general anesthesia. Corneal traction suture was passed for improving the exposure of the superior conjunctiva. Conjunctiva was cut with Vanna scissor and fluid was injected beneath the Tenon's capsule to create a smooth separation. Conjunctival incision was enlarged and Tenon's capsule was dissected from the scleral tissue gently. Limited cautery was done. A scleral incision was done to create a triangular scleral flap. Recent knife was used to create a partial thickness scleral flap. Cruciate incision was being made to expose the Schemm's canal for trabeculotomy. But suddenly we noticed a blackish discoloration of sclera just behind the scleral flap. Even though there was no full thickness entry, we suspected a choroidal hemorrhage and mannitol was immediately started. We planned to go ahead with trabeculotomy alone and abandon trabeculectomy. We made another cruciate incision as the first one was difficult to visualize because of bleeding. Nasal Schrems canal appeared sclerosed, probably due to previously done goniotomy. Temporal trabeculotomy was completed. Scleral flap was promptly sutured with 10-0 monofilament nylon. The choroidal hemorrhage had started to reduce. And had almost disappeared during the process of scleral flap suturing. The sutures were buried. The Tenon's layer and conjunctiva was closed in layers. Subconjunctival antibiotics and steroids were given. On first post-operative day, the right eye had shallow anterior chamber with intraocular pressure of 6 mm of Hg with reddish hue of the choroid. We prescribed topical steroids 2 hourly with cycloplegic and antibiotics on post-op day 11. Right eye had normal AC depth with IOP of 16 mm of Hg with reversal of reddish hue of the choroid.
Well, the surgery is well done. No doubts about it.
ICS tunnel. Since the pupil was irregular, an attempt was made to retract the iris to check for haptic position.
That's
Note
okay,
the
no
dense sombering ring.
Audio.
Iris hooks were used
Audio
to
is
better
not
visualize the extent of the ring.
Not audible.
AB team, thoda volume. Can you check the volume, please?
By manual automated vitrectomy was done and then switched to IA cut mode to remove the ring. As expected, it did not budge. A spatula was then used to try to free the ring from the equator of the bag. IA cut mode was again used to disengage the ring from the bag, but all attempts were only pulling the weak bag. The fear of dropping the IOL was always there. Finally, a chunk of the soldering ring was expelled out. It was now decided to explant the IOL instead of risking an IOL drop. Back to square one again. With gentle pull, the ring was attempted to tease out of the bag, but all maneuvers were only pulling the bag. How long can this go on? It was decided to sacrifice the bag and remove this ring altogether by visco expression. Leaving so much lens material inside can lead to refractory inflammation and glaucoma. Automated vitrectomy was again repeated and the anterior chamber cleaned up. After securing a relatively round pupil, iris claw IOL was enclaved. The main port was sutured and visco washed from the AC. A surgical PI was done and the case closed finally. Many lessons learned in this case. No surgery is a simple surgery. Always be prepared for surprises.
Thank you, Prasanna, for showing a nice video. Judges?
No, I missed the beginning part. When was the surgery done?
This patient had the surgery done. It's posted for resurgery.
No, but when was the original surgery done?
3 days prior.
Only 3 days.
Yeah.
Okay.
What is the three-piece lens, is it?
It was a three-piece lens.
So understand one thing, you have a three-piece lens. Now you got a sombering ring, so just to tell everyone here, okay?
No, but in 3 days, why should you get a sombering?
No, the patient had shallow AC with wound leak. It was a temporal.
No, sombering ring.
It can't happen in 3 days.
Sombering ring 3 दिन में कैसे होगा? That's what I'm
Remaining cortical matter only, not a
cortical matter cannot be sticking.
The primary surgeon did not remove the sombering ring. Had placed there was a rent.
What do you mean?
So three surgeries have happened. Two surgeries happened.
This is a resurgery, sir. So the first surgery, there was a rent. So the surgeon had placed a three-piece.
So when was the rent?
Must have happened long back.
No, intraoperatively.
Huh?
How many years back?
No.
First surgery, IOL surgery was done when?
Prasanna, देखो sombering ring है ना? How you will get the sombering ring immediately? The sombering rings would have been a Only a
Yeah,
surgery.
it was a sort of absorbed cataract. That's what was written in the first surgery note. So the surgeon had placed, there was a rent. So the surgeon had placed the 3-piece lens in the supposedly
I am slightly
sombering ring.
confused. The only thing that we are trying to ask is a sombering ring doesn't happen when you are doing a surgery. What was the pre-op diagnosis of the case then?
He's now saying
Yeah,
absorbed
it
cataract.
is sort of an absorbed cataract bar phacolytic glaucoma. So that was the first diagnosis.
Even if it is a phacolytic glaucoma, you can't have sombering because the entire cortex is liquefied.
Correct.
Yeah, this is what we saw on
Anyway, it
most of
doesn't
the
matter.
data.
Anyway.
Yeah.
So anyway, the point I'm making to you is if you have a sombering ring, you have a 3-piece IOL, na? You should have glued that lens, that will become a scaffold. Then the sombering ring can be put over the IOL. Then you can phaco or you can bop it out, whichever one you want. So what happened? You got out of it, luckily, otherwise that thing would have gone down. The sombering. Just telling you a trick for tomorrow in life for sombering rings.
The thing what we have learned, Prasanna, over a period of time, sombering ring can drop anytime, as what rightly said by Amar sir. The second thing, when it drops into the vitreous cavity, very difficult to remove it as well, because the cutter doesn't eat it like a nucleus. It becomes hard. And the third is a scaffold, definitely would have been the first choice. The fourth I would also like to add on is again a glued oil type of an IOL. You do lot many X-nits and all, because here try not to touch the iris. You already have trauma, couple of surgeries have done in the past. Fresh,
decision, boss,
you know, those kind of things should not even. Joshi sir?
Yeah, my only comment is use of triamcinolone in such cases, because you never know how much vitreous
That is
there
of
at the end
paramount
of-
importance. IVTA, usage of IVTA is of paramount importance. Rahul, final comments? Audience, wake up please.
Wake up.
We need an audience interaction. Dr. Sean, you would have done something different?
I would have asked for VR surgeons to stand by. That would have been a best thing.
Vitrectomy should have.
Standing only, sir. I am standing by you. Don't
Yes.
worry. Stand by.
Yeah, I'll just wanted to add here. Excuse me.
Yes, sir, please.
Yes, yes, please.
Actually, he
Alkesh.
was trying too much to remove that somewhere in ring, whatever it was with the cutter. I think simply you trata forceps, even if you have put it, you have taken it
Yes.
nicely, fully out.
Fully
There's
out.
a simple way rather than expressing, putting a lot of fluid, causing vitreous hydration, or putting visco behind into the vitreous cavity, causing further inflammation. Best thing would have just use you trata forceps, you could have taken out everything nicely.
I wanted to save the back till the last minute, but finally I
even
had
the
to
last
remove it.
moment also, while you were taking it out, you were trying though expressing out.
Yeah, okay.
So that moment also, even if you use Utrata, we get fine also. We need not to extend too much of incision also that way. And like later on, if you put glue, IOL, whatever you do, that's fine. But removal of that should have been much easier also.
Much easier, and sombering ring
And
always
causing
comes in piece.
no complication to the vitreous cavity. Because
Absolutely.
whatever we put, that goes into the vitreous cavity.
Absolutely agree. And sombering ring always comes in piecemeal, so you have to take it out from
See,
3
I am
4
still very confused. सोमरिंग रिंग बहुत पुरानी सर्जरी हो गई. अगर बहुत
understand.
पुरानी सर्जरी में कोई इन्फ्लेमेशन कॉज नहीं हो रही, कुछ नहीं हो रहा, then what is the and it's peripheral.
Peripheral.
See, that's the point. If it is 3 days old, it will be a very easily absorb. Well, you can easily pull out the cortex. So I am totally basically confused as regards
What was the purpose?
What was the
What
purpose
purpose
to do
of
it? If it is a sombering ring, then it's a very old surgery. And if a very old surgery is not causing inflammation and it is lying in the periphery, then that's something one can look at. But the primary problem to me is not clear as to what it is. Maybe you have so many cases, so you don't know the primary diagnosis, and your fellow would have done or whatever. But sombering ring hai to
At least 4-5 years
yeah.
like that.
Excuse me. So there is some confusion because it looks to be, as Maipal sir said, a long-standing case. We are also seeing some vessels or this so-called what are sombering rings or the epinuclear sheet what has been remaining behind. So it's a very chronic case which was there, and now we are handling it. And what was the primary motive? Whether the patient has come up with the inflammation or dropped vision?
No, she came for cataract surgery. This was probably, the diagnosis was absorbed cataract bar phacolytic glaucoma. So that was the...
He was referred by primary surgeon.
It was done like that and came to us. So
Okay,
that
okay.
is
Don't
what-
interrogate so much. We want him to be next year as well in the unplanned cut session. On a lighter note, Prasanna, but very well managed.
We are not
Prasanna,
planning
hats
to
off to
cut
you.
him from the next session.
Huh?
We are not planning to cut him from the next
Yeah,
session.
yeah, yeah. Otherwise, he'll cut you only.
No, this is the most unplanned case from me. from my side.
So he should be the
cut.
winner?
Yeah, he should be the winner because he still doesn't know the diagnosis.
Okay.
The whole case was unplanned.
Unplanned.
Okay, let's hear for Prasanna. We can have a round of applause.
Very nicely presented.
Very nicely
Prasanna.
presented,
Good.
Prasanna. Thank you
So,
so very much.
easy.
Careful,
Again
careful. Boy.
unplanned.
Yeah. So I request Manoj and all the judges and all the presenters to be here for a group photo. Joshi sir, Tiwari
You
sir.
have to declare the.
First we take a group photo and then we declare.
Acha, then they will run
Yeah.
away, is it?
They are planning. So, in spite of. It's a silent all, sir. Silent all. So now time to declare the winners. Yes, any guesses? The highest, yes, the highest mark, madam, Shubhangi madam. Please, all the participants be on the test. Dr. Shubhangi madam is the first winner, first prize winner. Second place goes to Dr. Avilasha Mohapatra. And Dr. Harshul Tak is also there, but he is not here present, so he is also in the top 3.
Ladies' Day out.
Yeah,
Clean
girl
sweep.
power, girl power.
Woman power, bhai. Congratulations. Many congratulations.
Yes,
Yes.
and
So we had
this
in the
year,
Namrata
this year,
Madam's office.
yes, this year we had some glitches. They had changed our hall in the last moment. This silent hall is not for such a session. It was a more interactive session. But whatever, we will plan it in a better way next year.
ठीक तब तक आपके अकाउंट में क्रेडिट हो जाएगा
Thank you.